Good afternoon. It is April 8th. This is our third series of question and answer. Again, I'm here with Gary Green, our infectious disease specialist. So Gary, we have some more questions for you this week. The first one probably is just what a week has passed. What's the status of Sonoma County?
So there's a lot of news media right now that we're heading into the surge, both nationally as well as locally. And I think Sonoma County is positioned pretty well. We know right now with the shared lab, about 7% of our swabs are coming in positive. But for Sonoma County Public Health, it's only 4%. So I think the county's dealing with the surge much better than a lot of other counties. I think the social distancing is really paying off. We haven't seen pockets of infection show up yet in nursing homes or in congregated areas. And so I think that our ER and our clinics, our respiratory clinic and the hospital, they're seeing a little bit of uptick in cases, but nothing yet. So I think that if the surge is coming the next week or two, I think if we keep doing what we're doing, I think our county is much better positioned for that. Other counties are really struggling. I mean, San Francisco, they're really trying to handle the surge. Santa Clara, they're handling the surge in different ways, but we're not at that level of panic, or we're not at that level of concern yet. We've been able to really conserve our PPE well here. And so because we have this respiratory clinic, I think, and we're careful in the hospital, and we're counting gloves, we're counting gowns, I think we've been able to use things really sensibly. So I'm really comfortable with how we're doing so far.
Yeah. I hear cautious optimism. So good.
Yeah, I am, if
Good.
we just keep doing what we're doing.
Yeah. Next question is kind of relevant to our practitioners because we're getting questions about it. This has to do with serology and antibodies and newer tests for that.
So my phone has been blowing up with serologic tests recently, both of docs and Sutter and also in the community, because it's been on the news. There's been a lot of news about the FDA granting an EUA status. What does that mean? So the FDA has granted the country emergency use authorization status to develop serologic tests. It doesn't mean we know how they work. So under an EUA, you can develop a test and not know its sensitivity, its specificity, and without validating it, you can use it. So currently, a number of serologic tests are coming up for availability, but we don't know how they're going to perform. The other thing about serology is that's where do you use it? If we have a good serologic test, how do you position it? What we know is that it takes about 2 weeks to develop an antibody response. So if someone's been sick acutely and they're coming into the respiratory clinic, we probably won't use serology. The nasopharyngeal swab is better. But someone may also come in and say, I was sick 2 months ago, did I have coronavirus? That's going to be an important question when we talk about vaccination. So down the road, when we think about who to vaccinate, you won't need to vaccinate someone likely with a positive antibody test. Right. We think that the antibody test is going to be very helpful with natural immunity. So once you develop an antibody response on your own, even before vaccination, you're likely not to get infected again. How do we know that? If you look at China, their epi curve came up and it came down to 3 months. If you didn't develop a natural immunity, China's epidemic would have continued week after week after week. So in the future, I think the serologic test could be more important for who goes back to work, and it's going to be more important for who gets vaccinated. Okay. So it's not ready for prime time. One other point about that is Shared Lab is looking at this. They're hoping to bring in a serologic test in the next week or two, but they want to validate it first, and I really commend them for that. They want to know if we have a test that's really a worthwhile test to use.
Okay, and when we talk about Shared Lab, we're talking about Sutter Shared Lab. It's our own
Sutter Shared Lab, that's correct.
Okay, good. Next question is also in the media on the news. It is point of care testing for diagnosis. What's the status?
Yeah, so I want to work with Sean. I've been working with Sean Franklin on that. I want to commend Sean Franklin because Sean and Rod Children have been helpful with trying to get point of care testing in. So Abbott came out with this new machine. It got a lot of press, and it can give you a negative result in 15 minutes, a positive result in 3 minutes. And Sutter actually bought 20 of those machines, and they're in short supply. And they position those machines at acute care sites like ERs and hospital. And I think that's appropriate for quick turnaround for patients that are going to be admitted or not going to be admitted, negative pressure room or not. But in the ambulatory setting, if we get more of those tests, Sean and I certainly want to bring that on. And Rod Children's been helpful in bringing in a point of care test. We may not see it in the near future. The good news is Shared Lab's turnaround time is 19 hours. So Sutter Shared Lab has really been ramped up, and their testing capacity is much better. It's much better than Quest. And I think we may not need that point of care testing in the ambulatory setting for outpatient use.
Good. Next is a question actually we got from Marjorie Bond. And this is something that is in the media. It has a lot to do with everybody's talking about it. That is contaminated surfaces and how to deal with that, or is it an issue?
Yeah, I think, Marjorie's question is a good one, and it's an important one. Elaine McCann, our infection preventionist, and I have talked about this a little bit. What surfaces are dangerous? What surfaces do we have to worry about cleaning? What surfaces does the virus live on? We know in a study of Singapore that in a hospital setting with a coronavirus positive patient, they tested surfaces, and all the air surfaces that were tested were all negative. We also know that they tested hard surfaces, and 1 out of 13 of those surfaces were positive in the room. So that's good, because that's different from RSV and influenza virus and C. difficile, for example. Another study in The Lancet showed that with SARS coronavirus 2, this novel virus, it lasts in the air about 3 hours, and 95% of it is gone within 1.2 hours. So that's why we want to close the door to a room and let the air exchange happen over an hour to clear out 99.9% of the virus. So the party line is, it can be in the air for up to 3 hours if someone is coughing and sneezing, but it probably is gone, most of it, 95%, by 1.1 to 1.2 hours. Hard surfaces are different. So we know that the virus can live on plastic the most. So it really lives on plastic for the longest time. It lives on metal surfaces not so long. On the longest time on plastics, this is 72 hours. And cloth comes in last. So it doesn't live as long on cloth. I think the reason is the virus dries out on cloth. It also probably adheres to cloth, and so it's not as much of a fomite there. But what I worry about in the hospital is my badge, my stethoscope, using your cell phone, because that surface, the virus may live longer if you don't clean it. What I worry about for patients is they go to Safeway, they get groceries, they come home with cans and bottles and bags of chips. Do they need to clean those surfaces? I think it's not unreasonable to clean them, but not vigorously, but to clean them so that everyone in the household feels safer by that. But on hard surfaces, maybe 72 hours, and in the air, maybe 1.2 hours.
Okay, well, that's useful. Well, I hope this has been helpful for all of you practicing and seeing patients, and also for your families. So stay safe.
Thanks.
Thanks, Gary.